This is your Chapter 32, Abdominal and Genitourinary Injuries. We're going to skip straight to the introduction. Alright, the abdomen is the lower of the two major body cavities. It extends from the diaphragm to the pelvis. It contains organs that make up the digestive, urinary, and genitourinary systems. All of these organs may be injured, but some are better protected than others. You must know where these organs are located and understand their functions. When an illness or injury occurs, you can then better assess its seriousness. Injuries to the abdomen that go unrecognized or untreated are a leading cause of traumatic death. A high index of suspicion and prompt treatment are required. AEMT review, your abdominal quadrants. And the abdomen is divided into quadrants by two perpendicular lines that intersect at the umbilicus. You have the right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. The quadrant location of bruising or pain can delineate which organs are possibly involved in a traumatic injury. The diaphragm is the dividing line between the thoracic and abdominal cavities. This may be injured along with abdominal organs. Hollow and solid organs. Owing to the size of the peritoneal cavity and the structures it includes, a patient could lose all of his or her circulating blood volume into this area without any visible external bleeding. Hollow organs include the stomach, gallbladder, intestines, ureters, and urinary bladder, and structures throughout which materials pass. They are more resilient to blunt trauma and less likely to be injured by trauma unless they are full. Solid organs are solid masses of tissue. They include the liver, spleen, pancreas, and kidneys. Injuries can cause severe hemorrhage. Abdominal pain from penetration or rupture of solid organs has a slow onset. Different organs of the abdomen are contained in the peritoneum, that's figure A, the retroperitoneal space, figure B, and in figure C, the pelvis. The genitourinary system. This is composed of the reproductive system and the urinary system. The urinary system controls the discharge of certain waste materials filtered from the blood by the kidneys. The kidneys are solid organs. The ureters, bladder, and urethra are hollow organs. The reproductive system controls the reproductive processes from which life is created. Patho. Injuries to the abdomen are considered open or closed and can involve hollow and or solid organs. General pathophysiologic concerns. Hemorrhage can occur when there is external or internal blood loss. Signs and symptoms will vary greatly depending on the volume of blood lost and the rate at which the body is losing blood. Key indicators of hemorrhagic shock will become apparent with the assessment of the neurologic and cardiovascular systems. As hypovolemia increases, the patient will initially experience agitation and confusion. If left untreated, hypoperfusion will result in anaerobic metabolism and acidosis. Peritonitis and pneumoperitoneum. Injuries to hollow or solid organs can result in the spillage of their contents into the abdominal cavity. Irritation of the nerve endings will occur. Pain is localized if the extent of the contamination is confined. Pain becomes generalized if the entire peritoneal cavity is involved. Peritonitis is an intense, potentially life-threatening inflammatory reaction. The first signs include severe abdominal pain, tenderness, and muscular spasm. Pneumoperitoneum may also occur as a result of rupture of a hollow organ, perforated peptic ulcer, recent abdominal surgery, or rupture of an abscess. Pneumoperitoneum, secondary to hollow organ rupture, requires surgical intervention. Closed abdominal injuries. A severe blow damages the abdomen without breaking the skin. Compression injuries are typically caused by a poorly placed lap belt. Deform hollow organs, increasing the pressure within the abdominal cavity. Deceleration injuries commonly occur when a person or the vehicle in which he or she is traveling strikes a large immovable mass. Crash injuries are the result of external factors at the time of impact. Solid organs are at the greatest risk. Shearing may cause tears from the ligamentum teres hepatis. Signs and symptoms are pain, tachycardia, decreased blood pressure, and pale, cool, moist skin. Crepitus in the lower rib areas may indicate broken ribs. Look for the Kerr sign. Pain primarily located in the right lower quadrant can indicate an inflamed or ruptured appendix. Pain that follows the angle from the lateral part of the hip to the midline of the groin can be the result of damage to the kidneys or the ureters. Determining the location of the pain or referred pain can be more difficult when the patient has voluntary or involuntary guarding. Bruises in the right upper quadrant, left upper quadrant, or flank may suggest an injury to the liver, spleen, or kidney, respectively. Bruises around the umbilicus, known as the colon sign, are predictive of significant internal abdominal bleeding. Injuries from seatbelts and airbags. Seatbelts occasionally cause blunt injuries to the abdominal organs. If the belt lies too high, it can squeeze abdominal organs or great vessels against the spine. Small children and short people who are in the front seat of the automobile may be at risk of injury when the airbag is deployed. Inspect beneath the airbag for signs of damage to the steering wheel. Open abdominal injuries. A foreign object enters the abdomen and opens the peritoneal cavity to the outside. Assume the worst, that organs have been damaged, and provide prompt transport. Gunshot wounds most commonly involve injury to the small bowel, colon, liver, and vascular structures. In penetrating trauma from stab wounds, the liver, small bowel, diaphragm, and colon are the organs most frequently injured. An evisceration goes all the way through the skin and muscle layer and through the fascia, resulting in bowel protruding through the skin. Signs and symptoms are signs of bleeding and puncture wounds, tachycardia, evidence of shock. The abdomen may become distended from the accumulation of blood and fluid. If major blood vessels are cut or solid organs are lacerated, bleeding may be rapid and severe. Injuries to specific structures, injury to the diaphragm. If the diaphragm is penetrated or ruptured, abdominal organs may be pushed upward into the thoracic cavity. Patients will exhibit dyspnea or feel short of breath, may have abnormal respiratory sounds, and may have an abdomen with a sunken concave anterior wall. Positive pressure ventilation with a bag mask device may be required. Patients with a ruptured diaphragm may become very anxious and short of breath if placed in the supine position. Any injury to the diaphragm will cause signs and symptoms of ventilatory compromise. Injury to the kidney. Kidneys are the most commonly injured organs of the genitourinary system. Blunt renal trauma results when the kidney becomes compressed against the lower ribs or lumbar spine. A ruptured kidney will usually present with pain on inspiration in the abdomen and flank areas. Penetrating renal trauma is more likely to be associated with injury to the liver, lung, and spleen. Injuries to the kidney rarely occur in isolation. A penetrating wound that reaches the kidneys almost always involves other organs. Suspect kidney damage if the patient has an abrasion, laceration, contusion, or hematoma to the flank region, a penetrating wound in the region below the rib cage and above the hip or in the upper abdomen, fractures on either side of the lower rib cage or of the lower thoracic or upper lumbar vertebrae. Injury to the liver. Liver penetration or rupture may quickly lead to signs of shock. Liver injury must be suspected in all patients who have right side chest trauma as well as abdominal trauma. Referred pain to the right shoulder may occur. Injury to the spleen. The potential for rupture is much higher if the spleen is enlarged from mononucleosis. When the spleen ruptures, large amounts of blood spill into the peritoneum, which can ultimately cause shock and death. Suspect spleen lacerations when fractures of the 9th through 10th ribs on the left side are present. Injury to the pancreas typically takes a high energy force to damage the pancreas. Patients with pancreatic injury tend to present with vague upper and mid-abdominal pain that can radiate into the back. The patient may also develop peritoneal irritation hours after the injury. Injury to the intestines and stomach. Intestines are most commonly injured from penetrating trauma. They can be injured from severe blunt trauma as well, resulting in peritonitis. Blunt trauma to the abdominal wall most commonly causes injury to the duodenum. Injury may present as back pain. Contamination of the retroperitoneum with duodenal contents may ultimately produce abdominal pain or fever. Abdominal pain, nausea, and vomiting may develop. Symptoms will not likely develop for hours to days. Most injuries to the stomach result from penetrating trauma. Trauma to the abdomen may cause injury to the small bowel, the stomach, and the large intestine. Rupture of the stomach causes rapid, burning epigastric pain, rigidity, and rebound tenderness. Injury to the urinary bladder. Bladder injuries are usually associated with pelvic fractures. Bladder injury should be suspected in any patient with trauma to the lower abdomen or pelvis. Blunt injuries to the lower abdomen or pelvis often cause rupture of the urinary bladder. If a bladder rupture results from sudden deceleration forces, urine may be spilled into any part of the abdominal cavity, leading to intraperitoneal, extraperitoneal, or retroperitoneal rupture. Injury to the external male genitalia. Testicular torsion can occur as a result of trauma. It is time sensitive and requires rapid transport. Injuries to the testicle or scrotal sac causes loss of fertility, and that is the major concern when patients sustain a testicular injury. Exact outcome depends on whether the testicle can be preserved via definitive treatment. Blunt testicular trauma can result in simple contusions, rupture of the testicle, and in rare cases, torsion or twisting of the testicle. Penis injuries. Injury to the penis may result from blunt or penetrating trauma, but also may arise from sexual behavior or self-mutilation. A fractured penis may occur when an erect penis is accidentally impacted against the partner's pubic symphysis or bent too far via self-manipulation. Penetrating trauma to the penis most often results from gunshot wounds. Injury to the female genitalia. The uterus, ovaries, and fallopian tubes are rarely damaged because they are small, deep in the pelvis, and well protected by the pelvic bones. Penetrating trauma to the reproductive organs may result from stabbings to the lower pelvis or gunshot wounds. As pregnancy progresses, the uterus enlarges substantially and rises out of the pelvis, becoming vulnerable to penetrating and blunt injuries. Expect to see the signs and symptoms of shock with pregnant patients. Supine hypotensive syndrome. Injuries to the external female genitalia can include all types of soft tissue injuries. It is important to attempt to determine the possibility of pregnancy and remember that some medications and tests are harmful for a fetus. Vascular injuries. Blunt trauma can cause injuries to vascular structures in the intraperitoneal space. It often masks or is masked by other injuries. Significance of the injury depends on how many vessels were injured and the length of time that has passed since the injury occurred. Assessment findings differ depending on whether the bleeding is contained or there is an active hemorrhage. Abdominal aortic aneurysm, or AAA, might have developed and became worse due to abdominal trauma. Rectal bleeding is a common complaint and something that you may encounter as a chief complaint. It can be caused by sexual assault, rectal foreign bodies, hemorrhoids, colitis, or ulcers of the digestive tract. Patient assessment. The cause of an abdominal or genitourinary injury may be readily apparent as a result of the MOI, but the resulting damage may not be so apparent. Maintain a professional presence at all times when treating these injuries. When examining the patient, expose only what is needed and then cover what has been exposed. Your scene size up. Scene safety is your first consideration. Follow standard precautions. Eye protection is required when managing open injuries. Look for indicators of the MOI and consider early spinal precautions. If the wound is penetrating, inspect the object of penetration. With genitourinary injuries, be aware that the patient may avoid discussing the injury to avoid undergoing a physical exam. If the patient trusts you, you are more likely to learn the true facts behind the injury. Primary survey, evaluate the patient's airway, breathing, circulation, disability, and exposure, then immediately care for any life threats. Control any external hemorrhage and look for indication of internal bleeding. The evaluation of a patient who has abdominal or genitourinary trauma must be systematic. In trauma patients, life-threatening external hemorrhage must be addressed before airway or breathing concerns. Follow the X, A, B, C, D, E mnemonic. Remember to keep the airway clear of vomitus. Quickly assess the patient for adequate breathing. Evaluate the patient's pulse, skin color, temp, and condition. If you suspect shock, treat the patient for shock according to your protocols. Early assessment of the abdomen. Perform a rapid full body scan of the patient. If you find a life-threatening problem during the scan, stop and treat it immediately. Examine the abdomen closely, looking for decap BTLS and hemoperitoneum. History taking. Obtain a history of the present illness using the OPQRST mnemonic from the patient. If the patient is not responsive, attempt to obtain a sample history from friends or family members. Ask whether the patient has experienced any nausea, vomiting, or diarrhea. Ask about the appearance of any bowel movements and urinary output to check for any blood in the urine, black tarry stools, which is melena, or the presence of blood in the stools, which is hematochezia. The incidence of repeated or previous injury or illness involving the genitourinary system can help determine the extent of the current injury and possibly the MOI. On your secondary assessment, you may need to perform this en route to the ER, obtain a full set of vital signs, including pulse rate, blood pressure, respirations, O2 sat, mental status, skin condition, and pupils. If the patient is experiencing external or internal hemorrhaging, monitor the vital signs closely with a degree of suspicion. In a patient who has an isolated injury to the abdomen with a limited MOI, focus your assessment on the isolated injury, the patient's complaint, and the body region affected. Perform the physical exam on all patients with abdominal injuries in the same manner. Remove or loosen clothes to expose the injured regions of the body. Provide privacy as needed or wait until you are in the back of the ambulance. A patient without suspected spinal injury should be allowed to stay in a position of comfort, and with patients with a spinal injury, place padding such as blankets or pillows under the patient's knees. Examine the entire abdomen, including all posterior, anterior, and lateral surfaces. Look for the presence of contusions and abrasions, which can help localize focal points of impact. Note whether the patient has hematuria. Pain assessment. Peritonitis can take hours to days to develop. Nonspecific symptoms such as hypotension, tachycardia, and confusion may not develop until the patient has lost more than 40% of his or her circulating blood volume. Always maintain a high index of suspicion in any patient who has an MOI consistent with abdominal trauma. Abdominal distension is a late indication of abdominal trauma. Assess the patient's pain. Somatic pain comes from skin and muscle, as well as joints, ligaments, and tendons. This is often described as sharp and localized to the area of injury. Visceral pain comes from organs inside the body with injury or illness. Three main areas where visceral pain is felt is the thorax, abdomen, and pelvis, often described as a deep ache with cramping. Do not delay transport of a seriously injured trauma patient to complete non-life-saving treatments. For your reassessment, repeat the patient's primary survey and reassess vital signs. Identify trends in pain, vital signs, and the progress of treatments will help determine whether the patient's condition is improving. Communicate the MOI and injuries found during your assessment to the hospital staff. Document the results of the physical exam and any pertinent negatives. Be cautious and diligent when dealing with patients who refuse transport to the hospital. Contacting medical control for assistance to convince the patient of the need for transport can be very useful. Assessment and management of specific injuries. Patients presenting with blunt trauma and evidence of substantial abdominal trauma are potentially not reliable. They should undergo spinal immobilization or spinal motion restriction. High flow oxygen should also be administered. Consider the use of pneumatic anti-shock garment for an unstable pelvis if dictated by local protocol. Most abdominal trauma injuries require rapid transport to the closest, most appropriate facility. Provide emotional and psychological support en route. Closed blunt abdominal injuries. A patient with a blunt abdominal injury may have one or some combination of severe bruises of the abdominal wall, laceration of the liver and spleen, rupture of the intestine, gallbladder, or stomach, tears in the mesentery, rupture of the kidneys or avulsion of the kidneys from their supporting structures, rupture of the urinary bladder, severe intra-abdominal hemorrhage, peritoneal irritation and inflammation in response to the rupture of hollow organs. If you suspect injury to the diaphragm, focus on the airway, breathing, and circulatory status of the patient. Immobilize any patient who has sustained a blunt abdominal injury. Monitor the patient's vital signs for any indication of shock, and keep the patient warm with blankets and provide prompt transport to the ED. Open penetrating abdominal injuries. Patients with penetrating injuries generally have obvious wounds and external bleeding. Only a surgeon can accurately assess the damage. Assume that the object has penetrated the peritoneum, entered the abdominal cavity, and possibly injured one or more organs. Follow the general procedures previously described for care of a blunt abdominal wound. If the penetrating object is still in place, do not remove it. While manually stabilizing the object in its position, apply bulky dressings around it to control external bleeding. Initiate 2 18-gauge IV lines or larger and follow local protocol. Increasing blood pressure can increase internal bleeding, so fluid should be given in a volume to maintain perfusion to vital organs. Abdominal evisceration. During assessment of an evisceration, do not push down on the patient's abdomen. Perform only a visual assessment. Never try to replace an organ that is protruding from the abdomen. Cover it with sterile gauze, compresses moistened with sterile saline solution, and secure them with a dry sterile dressing. Provide other emergency care as necessary and provide prompt transport to the ER. Provide high-flow oxygen transport according to local protocols and destination policy. The open abdomen radiates body heat rapidly and must be covered. Cover the wound with moistened sterile dressings and with an occlusive dressing depending on local protocol. Secure the dressing with a bandage and secure the bandage with tape. Kidneys, you will see signs of shock if the injury is associated with significant blood loss. Another sign of kidney damage is blood in the urine. Treat shock and associated injuries in the appropriate manner. Provide prompt transport to the hospital, monitoring the patient's vital signs carefully en route. Urinary bladder. Suspect a possible injury to the urinary bladder if you see blood at the urethral opening or physical signs of trauma on the lower abdomen, pelvis, or perineum. The presence of associated injuries or of shock will dictate the urgency of transport. External male genitalia. A few general rules apply to the treatment of injuries. Injuries are very painful. Make the patient as comfortable as possible. Use sterile, moist compresses to cover areas that have been stripped of skin. Apply direct pressure with dry, sterile gauze dressings to control bleeding. Never move or manipulate impaled instruments or foreign bodies in the urethra. If possible, always identify and take avulsed parts to the hospital with the patient. Managing blood loss is your top priority in amputation of the penile shaft. Never apply a constricting device to the penis to control bleeding. Explain all procedures to alert patients to reduce anxiety in an already stressful situation. Testicular torsion should always be suspected when there was direct trauma to the testicles. Transport the patient with these injuries rapidly to an ER that has ultrasound capability and an available urologist. No attempt to remove the tight objects around the penis, testicles, or both should be made in the field. The patient should be transported to the hospital for proper evaluation and treatment. For female genitalia, lacerations, abrasions, and avulsions should be treated with moist, sterile compresses. Use local pressure to control bleeding and a diaper-type bandage to hold dressings in place. Leave any foreign bodies in place and stabilize them with bandages. Bleeding may be heavy, but it can usually be controlled by local compression. Contusions and other blunt injuries all require careful in-hospital evaluation. The urgency of the need for transport will be determined by associated injuries, the amount of hemorrhage, and the presence of shock. If you believe your patient has been sexually assaulted, do not examine the genitalia unless obvious bleeding requires you to apply dressing. All right, that is it for chapter 32.